Welcome to our last, I guess, breakout session of the conference, and philanthropy's role in addressing Virginia's youth mental health crisis and its impacts on education. I'm Sari Raskin, and I'm representing the Community Foundation for Northern Virginia. We are one of the co-sponsors with the Potomac Health Foundation, who you'll hear from a little bit later, for this session. And we are so excited. I'm here with my colleague Elizabeth Hughes, who's our director of our Insight Region, our Data and Research Center at the Foundation. And we are really just very excited to be here and sponsoring this session. We at the Community Foundation for Northern Virginia are committed to this issue of mental health. We recently hosted an event in March, our Shape of the Region conference, that was focused on access and affordability of mental health services and the issues and barriers around that issue. Debbie Oswald, who I'll be introducing in one moment, was one of our panelists, and it was a very informative session that really brought together leaders. We had 17 partners, including 9 chambers of commerce. Also included our local community college, George Mason University, a variety of partners. And our goal is to continue over the next year to promote mental health and the issues around it, both through research and you will see on your table is our Finding Our Way Back to Mental Health report on your table. Please take one. If you need more, we have plenty. We also have a half pager with just basic information that you can hand out as well bring back with you if you'd like. And we're committed both from an investment perspective. We just basically funded our endowment that we had as part of did our event, and then are also creating additional reports over the next year that are focused around this issue area. So again, very excited to be part of this process, this conference, and I'd like to introduce Debbie, who will introduce our panel, and again, thank Debbie for participating in our event a few weeks ago.
Thank you, Sari. And I have to say, the event that the Northern Virginia Community Foundation did was outstanding, and Elizabeth did yeoman's work on research about the mental health needs and situation, especially for adults in the Northern Virginia region. And if you are interested in that, or even at looking at the survey instrument that she developed, because you see all the answers, please go online and look at it. It's called Shape of the Region. It is where you would look on their website. I've actually gone to it several times since then. But it was really outstanding, and they're really doing a great job there. So kudos. And so I don't think it's a secret to anyone that mental health has become a huge issue, even bigger than it was before the pandemic. I do like data a little bit. And so, one of the things that really just has struck me is that, BRFIS, does everybody know what the BRFIS survey is? I hope so, because I can't remember what the acronym stands for. But it's a survey that the CDC does constantly. It's a set of questions, and the CDC asks the questions monthly in every state, is constantly surveying throughout the country. And one of those and it's been doing it for years. And one set of those questions has to do with the state of mental health of the people who are the respondents. And things like, have you had more than 14 bad mental health days in the last month? That kind of thing. So it's self-reporting. So in Virginia, prior to the pandemic, the number of people who reported, bad mental health days and that sort of thing was about 10%. It was a 10% average each month. When the pandemic started, shortly after that, like in May of 2020, it had skyrocketed to 41%. Today, well, I don't know today, but a couple months ago when I last looked at it, it was 35%. So over a third of Virginians are experiencing poor mental health days and issues. And so to me, that is astounding and really problematic from so many reasons. We've read in the papers over the course of the last year or so about the problems with our public mental health system, a system that deals with and tries to help with folks who are seriously mentally ill, and also emergency cases that show up in the hospital emergency departments. A lot of state legislative and executive branch focus on that important work. I think that what gets lost in that is the other end of the mental health continuum, where you have so many people suffering from depression, anxiety, panic disorder, what I, in my lay frame of mind, think of as basic mental health conditions. And when you think about it and look at the data, the number of people who are seriously mentally ill and that the public system works with and tries to help, it's a lot of people, but it's a very small number compared to the huge number of people who need some help with some basic mental health conditions. And so, there are, and that's all just to say that there are so many opportunities to do some good work in the area of mental health. And these are needs that people of all ages, incomes, demographics, geographics have. This is everywhere. Today, we're going to be focusing on children's mental health, and we're going to, I'm going to give you a little overview of what we're going to do here today. So, and then I'll introduce our speakers. And so, first we're going to hear, well, maybe I'll so first we're going to hear from Emily Griffey, who is from Voices for Virginia's Children, a statewide advocacy organization that is going to give you, she's going to give you a kind of a big picture of mental health needs of children in Virginia and just set the stage in a way. And then we're going to hear, and let's see, what order then we're going to hear from, then we're going to hear from Valerie Liggins, who is with the Cameron Foundation, and she's going to share some of the work they're doing in their service area, Petersburg and surrounding counties. Okay, and then we're going to hear from Michael Lyons, who's from the Virginia Partnership for Mental Health, for School Mental Health. And that's kind of self-explanatory. And so he's going to share with you, this is my old age brain, okay, but he's going to share with you the some work that they have done too. These are just two, I shouldn't say the word just, these are two examples that we're sharing to kind of stimulate thinking and, get the wheels turning. Then, and after each is done speaking, that's when you get to ask your question of each speaker, because I lobbied for that because, I can't remember from one speaker to another anymore what questions I have. So I thought there might be a few others like that in the room. So, so you get to ask your questions after each one is finished. Then we are going to you'll see that your tables have little, what do you call those things? Thank you, table tents. I'm looking right at them, table tents. This is really evidence of senility. And so have table tents that have different subject matter on them, and at the appropriate time, you will have the opportunity to go to a table with the subject matter that you get to pick and talk to others related to it. So that's the gist of it. Now, in other instances here, everybody, the table, we've broken into groups, we've talked about things, and then we've reported back. Well, we're not doing that here today. Instead, you will see hanging on the wall, where's Robin? Yeah, so Robin is like Vanna White. So you will see hanging on the wall a place where, and you will see stickies on your tables along with the table tents, and that as things come up that you have that have been aha moments for you today that you want to capture or let us know, or hey, this is something that's really interesting to me, or this is something that I really would like to pursue further, or I would like the Virginia Funders Network to, elevate and look into more. We want you to please write that on a sticky. And you can have as many stickies as you want, like if your brain is just full of ideas and things that you want to give us feedback and suggestions, and just post them on that hanging thing. I don't know what we're calling that. It looks like a piece of cloth to me. But anyway, okay? Got it? Okay. So there's one last thing. I'm supposed to do it at the end, but I'm going to do it now because I think that it has to do with the delivery of mental health services. And that is, I just want to make sure that everybody knows that we are going to face, this coming summer most likely, a time when it's actually a pretty dangerous time for people who have Medicaid, because essentially the feds will require will start to require annual renewals of eligibility once again. That has not occurred during the pandemic. And so we have over 2 million people who have Medicaid in Virginia right now. That's about a quarter of the population. They call this the unwinding. I don't know why, it makes no sense. I'm just telling you that it is reinstituting the requirement of annual renewal. There are people who have Medicaid coverage right now who got coverage and were eligible when they signed up because maybe they lost their jobs during the pandemic or that kind of thing, and who will ultimately, not be eligible when the redetermination occurs. And so, fair enough. There are also lots of people, including all age blind and disabled, who are still eligible for Medicaid, and unless we are all very attuned and active and engaged, we'll lose their coverage because they don't know that they need to renew, maybe because they didn't get the letters telling them to do that, because maybe they've moved and they haven't updated their contact information, or maybe it's just too complicated and they are stymied by it. But this is something this is going to be the biggest enrollment event in the history of the Medicaid program that we begin to undertake. What we've been told is probably around July 15th, although that's still up in the air. We'll know more actually by the end of this month. And so this is something that VFN is sponsoring a virtual workshop on, or webinar, whatever we're calling that. So if you want to learn more, we'll have folks from DMAS and elsewhere to just talk about how you can make a difference in your communities. But I just have to put in a plug for that to make sure, because there are a lot of people who are not aware that this is about to occur. And so, enough said. Okay, onward. Emily, welcome.
Thank you. Can you hear me okay here? I think so. Great. Well, thank you so much for having me here today. I am Emily Griffey. I'm the Chief Policy Officer at Voices for Virginia's Children. Sorry, Allison Gilbreth can't be with you today. She's our Policy and Programs Director, but was not feeling well in terms of all the timing of kid illnesses and various illnesses. I hope you'll understand. But one thing about Voices for Virginia's Children and our work that hopefully I'll be a good substitute is that we believe there is a whole child approach to child well-being and policy. And so we work across all of our issue areas, particularly around well-being and mental health. So this is one way that we provided our approach to working on advocacy and policy. Our focus is on child well-being. We specialize in areas around early education, around access to health care, so been deep in the weeds on the unwinding issues as well, on the foster care system, and of course on the mental health system. And then we look at cross-section issues around trauma-informed care and racial justice. Our hope is that we can work with legislators to identify bipartisan champions for children's policy issues in the state and to really create those legislative changes, policy changes, and systems changes that are going to produce better outcomes for our kids and the future of Virginia as a result. Our first slide that I'm going to start off with is actually the voice of a young person who was a part of our youth advocacy cohort during this past General Assembly session. So I'll turn it over to Melissa, because one of the things that we find is so essential in our work as advocates is to listen and lean into the experiences of young people in these systems as they're experiencing them. So I think we're ready. I'll advance the slide here to hear from Melissa.
As defined by the CDC, mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. Mental health is not a joke. Mental health is not a trend. Mental health is not just a hashtag. So much of what you experience as a child influences who you are as an adult and how you function, including learning behaviors and forming habits. Our youth need your help, from passing supportive and vigorous legislation to changing the way we talk and think about mental health. Youth carry so many untold stories of burdens, truths, and hardships, which have only been exacerbated by the COVID-19 pandemic. As a kid, you see what's going on. We might act like we don't, but we do. We see life happen and the struggles our loved ones face, and we internalize those observations and experiences. Frankly, because we're unaware of practices to help us process our feelings and thoughts. Or in many cases, our communities lack adequate resources or have extremely limited resources. The just deal with it, you'll be fine, get over it, and suffering must stop now. Resilience is a powerful skill and shouldn't be dismissed, but eventually there comes a time when bouncing back becomes harder and harder to do. The pushing through or dealing with it is simply no longer a viable option. I know this to be true because I share similar stories with countless children and young adults. Whether it's trouble at home, anxiety, depression, or surviving a pandemic, we need help. We need resources. We need access to safe spaces and tools centered around mental health and wellness. Learning to care for your well-being is an essential life skill. Life circumstances will never be perfect, but when we know how to check in with ourselves and check on one another and where to go to receive help, we can begin to transform our lives and ultimately our communities. What better way to normalize mental health than to prioritize mental health and shatter stigmas, especially in marginalized and BIPOC communities? Virginia doesn't have the luxury of not prioritizing this critical matter any longer. Resources, especially because of the pandemic, are in high demand and vital to everyone, but particularly vital to youth. Youth are being told their problems aren't bad enough, and they don't meet the criteria to receive services. They're being turned away. Our children and young adults are looking to you and pleading for help. How will you show up? Thank you. And I'll turn it back over to you, Amy. Thank you again.
Thank you. So Melissa kicked off one of our press conferences
Thank
we
you, and
had during the legislative session with a group of bipartisan legislators who are also looking at lifting up children's mental health. I'm going to highlight a few of those issues because our legislative session, as you might know, is not quite over yet in Virginia. So hopefully we can get some action. So I think getting some context to what Melissa pointed out, she said mental health is not a hashtag. And I want to also emphasize that for folks because this is Mental Health Awareness Month. This is Children's Mental Health Week. This is the week when literally mental health becomes a hashtag. And I think that that's very powerful in some ways. We have to listen to Melissa's statement as well and understand it can't be only this week that we're paying attention to this issue. It has to be part of navigating a new normal. And so I think the examples that she described of being able to help her peers, being able to get help where she needed, are the types of policies that we want to see move forward and be in place to really support young people as they navigate a new normal where mental health is a part of your overall well-being. So some of the things to point out in the context in Virginia is that we, of course, did see an increase in children's mental health needs and priorities during the pandemic. Both parents identifying needs of their children, particularly young children, and children themselves identifying greater needs. There's more recent information around increase in emergency room visits for children with suicidal thoughts and needs, so that we know that there's a lot in that space as well. And we're seeing right now, in particular, a lot of children who are harder to place in the foster care system because they don't have access to mental health services and placements as well. So our system across the board has numerous points where it is breaking, and the number of mental health professionals to meet the need is inadequate. I'll also note that in terms of health insurance coverage and Medicaid, we want to make sure kids have access to Medicaid, and that Medicaid reimbursement rates and coverage covers these services, but private insurance also really doesn't cover many of these services for children's mental health in particular. And so we have sort of two problems here with the coins, with the side of the coins of the payers in this system, and providing better access for kids. And I also just want to point out that where we would really like to go is this intersection between education and starting early on, starting with early childhood education and supporting kids' mental health throughout the continuum so that we can prevent these harder to serve issues, the emergency room visits, the hard placements in the foster care system. So we believe that the next steps moving forward are really an integrated approach to mental health, where all parts of our system, especially along the education continuum, especially on what happens in the classroom, in the after-school programs, in summer programs, and in early education, are supporting mental health as well. So one thing that we look at when we look at the state mental health system is how much state funding and resources come to children's mental health. And one area that is true in children's mental health in particular is that there's little pockets of funding in almost every system. There's a little bit in education, a little bit in juvenile justice, correction services, and in the Department of Behavioral Health and Development, which is really our biggest system for mental health. And when we looked at the budget just for the Department of Behavioral Health and Development, which funds some programs out of the state office, but mostly services at your community services boards, your CSBs in your localities, less than 10% of that budget went to children's services out of our whole mental health system. And a constant theme that we've seen in our advocacy for children's mental health is that children's services get put in phase 2 or plan B. Like they're never the first step in the problem, even though we know that's where we could combat issues along the line. So we are hoping that raising these issues, how much funding goes to mental health, but we need to move outside of just phase 2, can really start to put a better spotlight on children's mental health needs and the role that the state can play. We've seen the previous governor, the current governor, say a lot of interest in mental health and improving the mental health system, we really want to see champions particularly focused on children's needs. So some of our vision for alignment across the systems are to first address the workforce barriers. The Virginia Healthcare Foundation has a great pilot that will hopefully get funded, fingers crossed, very soon, to address workforce shortages. And what did you say? It will, yes. Address workforce shortages and pay for some of the time that staff would need to meet for licensure. So that's one immediate step. We also would like to make sure that school systems are able to have the resources to pilot more services, particularly at what we call Tier 2 or Tier 3 systems, where the schools have sort of identified higher levels of need, higher level of acuity of kids. They feel that the work over the last few years to increase the number of school counselors and other support staff has really been able to help provide a universal approach in school, and they're getting better about social emotional well-being. But it's when you start to see some needs about screening and identification and creating groups or providing direct services that schools are having a harder time being able to meet those needs. I'd also love to see a new opportunity that will be coming this summer, a Medicaid opportunity, is for schools to be able to bill for services outside a child's IEP and bill to Medicaid. This will be coming from a new set of regulations from our Department of Medicaid Services over the summer. And it's going to require some technical assistance for schools to do this because it's a little bit wonky and back-end administrative tasks to be able to bill for Medicaid. But it would bring that dollar-for-dollar match for what the school districts are paying right now if they had that technical assistance and support. And then, of course, what we'd like to see at the state level is our state agencies working together better, particularly focused on where children are, wherever they are, if they're in a foster care system or in a classroom or being served at the community level. How can they all work together to help support children's mental health needs instead of the siloed approach that we typically have? And I think one of the biggest things is including Melissas in the conversation, including young people to be able to hear from their experiences directly, particularly in light of many of the changes and conversations that have been happening in the school systems lately around divisive concepts, racial justice, equity in approaches to mental health. I want to hear what matters to young people and how the approaches that make them feel safe, that make them feel well in school in order to succeed. And despite some of these conversations that we have heard from many students are producing additional anxiety and stress in their schools as well. The other thing I forgot to mention on the earlier slide, so one of the things that we've saw even prior to the pandemic that I think this relates to hearing from young people too, is that girls experience mental health issues more prominently than boys, as well as LGBTQ plus students. And we also know there's a number of policy issues and conversations targeted to LGBTQ plus students and gender identity, where this shouldn't be a surprise, but we can see as heightened anxiety and mental health concerns among that population as well. So a couple of things in our yet to be determined budget to flag our pilot effort to integrate mental health services and community-based services out of the Department of Behavioral Health and Development. The Senate approved $5 million for those services championed by Senator Jennifer McClellan, Senator Jill Vogel, folks who were standing up and speaking up for children's services. As we wait to see how much money is in the budget, that's one of the things that is hanging in the balance of how much money is there. What we'd like to see that pilot be able to do is to provide schools the resources when they're like, shoot, we're stuck, we don't know what to do in Tier 2, Tier 3, or we have a great community provider, how can we just don't have any resources to partner with. be able to unlock some of those approaches, and then be able to look at the state level at how does the state systems do a better job of supporting school divisions and community providers to make those connections as well. And another thing, while we didn't get the mental health task force this session, there is a school-based health services task force that passed and was approved in the most recent session that's looking at health broadly, but will include mental health in that approach as well. Medicaid reimbursement rates are another piece of this puzzle. This helps us ensure that children who are participating in Medicaid services are able to access these best services. We'd love to see these services more racially diverse, geographically available as well. But these are three areas that Medicaid, we think, can increase reimbursement rates. This first issue around the residential treatment facilities is also related to some of the current foster care crisis and the continuing the community-based services, as well as there's a very small student peer recovery network happening in Virginia. I think there's 2 student recovery specialists right now, but how cool would that opportunity be to invest in those peers? Thanks. I think I'm almost done. And the other piece would be a new pilot for a recovery high school in the Chesterfield area that has been in the works for several years prior to the pandemic. And funding is included in both budgets. It just, again, hasn't hit the signature to unlock it yet. But it would be a regional recovery high school that's been championed by Delegate Carrie Coyner. So these are our members of the General Assembly to contact if you would like to see some of these issues move forward and have any influence over keeping the budget negotiating happening. These are the members who are in the conference committee of the General Assembly, but we can go back to that slide at the end, because I always like to leave people thinking of a to-do around taking action.
Wonderful. Voices for Virginia's Children. I don't know, how many of you are familiar with the wonderful work they do? Okay, good. Because and Emily leads that effort in the General Assembly so well, and the research that goes behind it. And, you get things done with data and putting a human face on it, and then by establishing trusted relationships, and Voices and Emily have done that so well. And so thank you for sharing all of this with us.
Thank you.
And so does anyone have questions for Emily? Yes?
I'm curious why you didn't mention substance abuse.
Can everybody hear that? Why didn't you mention substance
I didn't
abuse,
mention
Emily?
substance abuse. We have some research on substance abuse, and some of the efforts out of the Department of Health and the Department of Behavioral Health are focused on substance abuse. But there, again, it's one of the things that isn't really connected in the mental health services field. The substance abuse folks are a little bit more specialized. The mental health folks are a little bit more specialized. And that's why I think this recovery high school model that I mentioned, I think will be a really cool opportunity to think about what does substance abuse recovery, mental health, education, health integration in a school setting look like, so that we might be able to address some of the substance abuse issues along with it.
Continue with that, and I'm
Yeah.
not remotely, I'm just an outsider who pays a little bit of attention to these issues. It would seem to me that substance abuse should be something that is integral to looking
I could-
at mental health for
Okay.
young people.
Well, I'm going to do my presentation, but one of my life before this was a substance abuse therapist. And so I worked for 2 local community services boards, and it is very much integrated. But I think because I wrote down what you said about the funding slide, the money to really push a lot of the initiatives forward. And people do tend to pull that out, even though the Department of Behavioral Health, it is very much integrated in a part. You have the adult SA mental health, and you have the youth SA mental health.
Okay, yes.
So Funder hat on, not Voices hat on. One of the things we've done is provide technical assistance to some of our grantees.
Wait, I think I should give you a microphone.
Oh, you never want to give me a microphone.
Stand here.
Ta-da! So one of the things we've done as a funder is provide some technical assistance to grantees in billing insurance, okay? And that, of course, has unlocked beautiful things. So I'm wondering, as you're talking about the schools billing Medicaid, if there's a place for, do they need technical assistance to learn how to do that? Might that be a good place for philanthropy? I don't know.
Yeah. I think it could be. I think there's some models of other states that have already moved forward with the free care rule that we can look to. Michigan, Missouri's done a lot around mental health Medicaid funding for schools, where we might be able to look to those models. We have a couple of localities who have already embraced some of the approaches, but I think a lot of it is waiting to see what comes down as the final set of regulations from the Department of Medicaid. I think DOE would appreciate it. I think that folks would jump on if there were some more opportunities to pull down the funding.
I just want to echo the statement around technical assistance, best practices. How do we, I think Dr. Hazel said it best earlier, bridge the gap? So for some venue like this, a lot of what we find is people just don't know how to have some type of hybrid billing model. And so they keep doing all this work when they could potentially have a source to make it sustainable. And I can't remember the analogy, but the drops in the bucket or the rocks on the program piles, we could solve for that if we had the ability to share some of that technical assistance and educate people around that capacity building and ways to access and unlock those funds. So thank you for everything you do, but I think that's a key takeaway for many of us. And I come from the perspective of trying to help. I come from the funding side and the recipient side of trying to help them navigate, and there's such a great need for that in the community.
Other questions? Yes.
Here I come.
Thanks. Great presentation. I'm from the National Capital Region, and we've had a lot of conversations with healthcare organizations about a state of emergency for youth mental health. So thank you very much for that. One of the things that came up in my conversations with Kaiser and with Children's National Medical Center, though, has been lack of actual mental health workers, and that they, do not have enough people to even deploy to the schools, or because I was thinking on-site care. I love the idea of the capacity building or TA to help them bill Medicaid. I love that, so I'm definitely taking that back. But I'm also recognizing that we have a supply chain issue that we need to think about, and they particularly mentioned to me the burnout of existing health workers, as we know, mental health workers, right? So many people leaving the field at a time when we critically need more people in the field, and so I was wondering if that was something you all were trying to grapple with as well.
Yeah, absolutely. I think that the workforce shortage is just huge. Diverse workforce shortage is huge. And it's just going to keep impacting the system for a long time. Oh, I think Dr. Hazel has some ideas about workforce shortages.
I might. Bill Hazel, Claude Moore, on the workforce thing, I think you're right. Much of this human services and health thoughtful depends on actually having people to provide the services. It's one thing to have the benefit, it's another thing to get the service. And Debbie knows the access problems are real. In Northern Virginia, I can tell you we see an issue where the county will hire family service workers, right? Trauma-informed, working with the families. They're lost to the school systems because the school systems have better hours. There's no one in the school system meeting Afghani refugees at Dulles Airport in the middle of the night. Or they leave to go to Fairfax, which just offered a $3,000 bonus for sign. And they'll go to Fairfax for a while, and then they'll go to Prince William when they up the ante and we're playing musical chairs. So that's one problem, and it all stems back to not enough. Debbie has been focused on the prescribers piece, because for a few years, the challenge was that, well, we don't have enough high-level prescribers, particularly around substance abuse. was a big piece, and then the therapist, and she's got the nurse practitioner program that's running. But what we've done as a result of Sari and Elizabeth's conference is Elizabeth and I presented at the Regional Commission, which includes Arlington, Alexandria, Fairfax, Prince William, and Loudoun. And we basically were outlining the problems, and to me, it was a surprise that people didn't already know this. That's what bothers me. We assume things that others really aren't paying attention to. But Elizabeth made the case, and then what do you do? So we have a meeting at the Regional Commission coming up on the 31st where we're going to bring in partners from each of the localities and partners from George Mason and other places, and so we're going to say, all right, how can we fix this? And there are really some things to address. One is the working conditions. If you don't address the working conditions, and we found this as secretary, your first line is of behavioral health in the public sector is generally social work. So we hire somebody out of school. They may have had lived experience, but then we put them in a social work agency where they are not supervised by someone who understands social work, where the services that they were taught were going to be available aren't available. Then we ask them on Friday night, because they're low personal and totem pole, to go to the house where the kid needs to be for a family violence or neglect and abuse thing. Then we take a baby, and they quit. They quit within a year, like at 60, 70%. So there's no career path. So we're going to ask the localities to work together to design a career path. That's one thing, or several career paths. Then the next thing is we need people to train. And this is a part of the issue there in nursing and in behavioral health, is that the standards have risen so that once upon a time the next person up would supervise you, and now you have to have your master's degree to supervise. Well, we need those master's degrees people treating. So we have to look at that piece as well. And then, so those are just a couple pieces of the puzzle. Then we need to get people in the pipeline. And there are two sources. One is folks who are midlife, who are reskilling and upskilling, who may have the social emotional maturity you have to bring in. So how do we get them into a program that takes you, say, from what you have been doing to something you want to do? That's one piece. And the second is, how do we bring kids up in a fashion that allows them to mature enough? Because the issue is real. You can get people into it, but they can't do it. And so these are the things that we're working on. We funded a study for the Department of Behavioral Health last year. There is on the average about 1,000 vacancies in the workforce in the state behavioral health, mental health hospitals, which is why they are closed for admission, and why Commonwealth Center for Children and Adolescents has closed about, a quarter of their beds, because they don't have staff. So there's no backup. And then the other piece is the CSBs, as of last August, were short 2,400 people. So this is a huge issue that we are working on as part of our health workforce pipeline strategy, and I'm happy to talk in detail with anyone who wants to work on this with us.
Thank you, Bill. Okay, if you have more questions, you'll have to hold on to them, because we have to move on and hear from Valerie, and I'm supposed to be the timekeeper, which is a mistake to make me the timekeeper. So. But Valerie, let's hear what you guys are doing.
I think, Good morning, everyone. Good morning. My name is Valerie Liggins, and I'm a senior program officer with Cameron Foundation, focused on community health. And we are a place-based funder. And as a place-based funder, we serve very specific localities. And we serve from southern Chesterfield to Sussex County. And so to kind of get a picture of that, we serve communities that comprise of urban, suburban, and rural communities. So they all have a different culture, different fabric, different strategy in which we try to engage. Looks really different. As a funder, as a place-based funder, we fund in 6 program areas. As a community health program officer, I focus primarily on healthcare and human services, but we can actually review grants in all the areas. We have 3 buckets of funds that we focus on. We focus on responsive, where we have 2 grant cycles. We focus on capacity building. We have a strategic partner with CNE. And then we also have a strategic partnership with Duke University. And then proactive, and I'm kind of going fast because I'm looking at the clock too. So if I'm going too fast, stop me. With the proactive bucket, this is where a lot of our innovative initiatives come through. This gives us an opportunity to look at things outside of our responsive grant cycle and think about how we can really engage partners in a very intentional way. And so with our proactive strategy, this is where a lot of our projects come under, like this one, the Mental Health Initiative. We also have 2 school-based health centers that are in 2 of our localities. We also have a teacher residency program that would fall into that proactive fund. We also have workforce development, in which we have partnerships and have been working with some of the local community colleges that would come under the proactive funds as well. And we also work in the environment space with one of our local nonprofits. Some of you may have heard of the trail that's from Ashland down to Petersburg. We're working with that part that's specifically with our localities. So those types of things would come under our proactive funds. And those are the things I think we get a lot of bang for our buck, so to speak. When COVID hit, and I'm sure all of us have stories about when COVID hit, we actually instituted a emergency program to address some of the needs of our communities. When we looked at the needs in the community, we really highlighted 4 specific areas: health and safety, education, general operating, and technology. We provided those grants to our local nonprofits to help them get through the challenges that they were facing in order to be able to provide services, keep their doors open, and really just kind of help them to sustain through the pandemic. In addition to that, we also had a separate fund for school technology grants. So even though we have one for education, we did a separate pullout in which our school divisions could each get a bucket of money to really upgrade their technology because of the virtual space. As we started to look at specifically what's next, I just shared that my background is social work. I'm still a licensed clinical social worker. When I came to the foundation in 2008, going to your question, one of the things that was really clear is a gap in resources for mental health and substance abuse. I worked with 2 local community services boards, Richmond and Henrico, and I really followed that same track with them. Substance abuse treatment therapists with adults, prevention with kids. And that was along the substance abuse piece under that mental health umbrella. And so one of the things that was acutely clear, as we said at the very beginning, is that there was a problem with substance abuse, mental health services, even before the pandemic. And so when you hit the pandemic, it's like, okay, we know we have a lot of challenges prior to. What are we going to do now when we have all of this added stuff? And so I began to have conversations in-house about, okay, we're dealing with the emergency funds and we're looking at all the different buckets, but how can we really drill our strategy down further? No one has the answer. We're still grappling with the answer, so that's the answer, the spoiler alert, so to speak. But one of the things that we did is we showed this graphic to our board to really try to get them to understand that this is a crisis, and this was developed before, as I said, the pandemic. This is what we're faced with now. Can you imagine what that's going to look like afterwards? And then I think, because at first I got a no when I really proposed that we really look at this and kind of really drill down to this. And I think just showing this graphic in a way that everyone could understand really kind of highlighted for our leadership that, maybe this is something that we really need to look at. So the goal became for us is to initiate a proactive look at mental health services and school systems so that we can gain an understanding of what those existing gaps are. And how do we as a foundation, what is our role in that process as we look at how do we help our localities? So what we decided to do is be the convener for that conversation. We invited mental health professionals, school administrators, health safety net providers, and we have a Southside Trauma Informed Network. We invited all of them to come to the table to have a discussion. We did this over a set number of meetings, which I'll talk about, but we really was very clear about who needed to have, as we said, they said yesterday, that cross-sector look at mental health and what could that mean. As a convener, we facilitated the conversations. I worked in sort of collaboration with our education program officer. All of our school administrators, they sent a representative. Again, we cover 7 localities, so they all came to the table. All had different vantages points in terms of how they see the problem. Our safety net providers also included mental health, not just the mental health, but also the substance abuse piece at the table as well. And of course, Trauma Informed Network, because definitely when we think about trauma and what we were going through. We hosted 6 focus group meetings. We ended up actually only using 5 of those meetings. And these are the questions that we kind of started with to kind of set the table, so to speak. Is there a role for the foundation in this space? What are the existing gaps that they saw in mental health services? How can existing funds be leveraged? Because we knew funding was coming. It's just a matter of what did that look like, and how long does our communities have to wait? You know, because there's a waiting period, and what does that gap look like? And what is the potential impact of us addressing mental health needs? Emily actually came to the second focus group meeting. I told her it's kind of ironic that she ended up subbing for Allison today, but she did the same thing that she did here. She kind of set the landscape in terms of policy and what type of funding opportunities may be available for some of our nonprofit, and to answer questions that they may have, and to say, you know, potentially how that can be effective in their role. So we had that as a part of that meeting. And so we continue with each of those meetings to have someone as a guest speaker to talk about things from their vantage point and to really kind of clearly articulate that conversation and those important pieces. Fast forward after the meetings, it kind of drilled down for us to 3 discussion points that kept coming up with our focus group participants: mental health access and supports. And so when they talked about mental health access and supports, it wasn't just as it relates to the children and youth. It's like, what about the teachers? What about the administrators? Didn't expect that conversation because, again, we were focused on the children and youth. They kept bringing us back to teachers and administrators as well. And so when we talk about mental health access and supports, we have that combination of bucket that we heard from those individuals that were boots on the ground. Workforce pipeline, I don't think I need to elaborate on the critical mass of that because we've talked about that, but that conversation was robustly discussed in our focus groups as it is here. And then we started talking about different brainstorm solutions, models, and pilots. Again, that was a little bit more difficult because, again, we serve rural, suburban, and urban communities. They all look different. Our rural communities have huge landscape, transportation, 3 schools. Urban schools, they may be within 2 or 3 blocks of each other. So, you know, it all looks different. So when you think about, you know, how do we come up with a model or a pilot that's going to serve everyone? It's definitely not going to be one size fits all because all the communities look different. So where we ended is we received recommendations from our focus groups to focus on medical and mental health access and supports, and to look at a long-term solution of the workforce pipeline. How we ended up crafting and how we ended up crafting that is, again, we went back to our proactive strategy and say, okay, hearing what our focus group participants are saying, what in how we craft our proactive strategy, what would this fall under? And we landed on the 2 buckets at the end: special opportunities, urgent needs with funding that's outside of our usual grant cycle, and projects with the potential to leverage significant funding opportunities. And so when we looked at what we would offer to our communities, we split it into 2 buckets. We have 7 communities, and they were each given consultation dollars and training and support dollars. The consultation dollars were used to work with the students, your FAP teams, your child teams, to really kind of help talk through issues that may occur with students in their community, to really have someone at the table to help them navigate, okay, to navigate resources that was a challenge. And then we had the training dollars for that support, where their teacher or administrator can say, this is what we need, this is where we need to have support through. What ended up happening with that is we had a conversation with Child Savers. Child Savers has a Richmond mental health pilot that was funded, I think, by Robbins some years ago. And they also spoke at one of our workshops with VFN about the pilot. And so we knew Child Savers has a wonderful reputation. They have always been a part of our community in terms of that dialogue. So they actually became the grantees, so to speak. We allocated 100 hours for each school district to use for their consultation dollars. And then they had a bucket of money to use for the training and administration piece of it. Now, they were required, and we talked with our school districts about that, they had to get an MOU, because we know what happens with school districts. They say yes, 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 and then sometimes they are overworked, overwhelmed, and nothing goes through. So we wanted everyone to be really clear about what was available and what would be their role in actually receiving the services if they chose to. We really stress to them that this is an opportunity to be as flexible and as creative as you would like to be. And if you decided that you did not want to participate in this opportunity, that was fine. It was not a requirement. It was just something that was offered to help navigate those gaps until you can get those individuals in the building that you needed to help your students and to help the teachers. All of our school districts, except for one, signed the MOU, and we proceeded to help with that. Another thing, added piece, we also have a community services board that is overworked and under-resourced as well. And we did not want to leave them out of the equation, because we knew that politically, that just would not be a good thing, is to not support our local CSB. And so they had a program called Another Chance Program, which was aimed at reducing long-term suspension and increasing graduation rates. It's a 6-week program. They also work with parents as well. We actually gave them a grant to hire someone to scale the program up. And so real quickly, when we talk about the challenges, the barriers, going to the workforce pipeline, they have been unable to hire anyone to scale the program up. So they have had to continue with the staffing that they have. This opportunity, I already talked with them, it will carry over next year. Hopefully they'll be able to get someone to scale it up. But they have been able to continue the program in some of the areas as they have done before, but they still need that position. When we think about with Child Savers, the organizations that have, or the school districts that have really grabbed a hold of this opportunity are urban school districts. So the 3 city schools that fall into that bucket, they have been gangbusters. One of the school districts, 2 of them actually have a school-based health center, and they are interested in bringing services inside. And then we also have one of our rural districts who already had a relationship with Child Savers to take advantage of the opportunity. So we already know trust building is an issue when we talk about some of our communities, and having to do more work on the ground with that to get them to understand that this is not a big brother, we're calculating the problems, but how can we help you? And so that's just some of the barriers that we've talked about. And I think I made my minute.
Valerie. And so, that's pretty cool what they did, don't you think? So questions for Valerie? I have a microphone. Denny.
Thank you. Valerie, thank you. That was wonderful. One of the things that I've tried to figure out is, from the philanthropy side, when we say we want to support your hiring of X number of folks, is there then the expectation of the school system, the CSB, local government, whoever it may be, that we're helping fund these positions for, to sustain that at some point? How long do we, as philanthropy, go, okay, we'll give you this position and we'll pay for this position? Is there a limit that you guys set for how long?
Did talk about this again, that this is that gap. And so we definitely put out that the sustainability is the issue. So this was a short-term, all of this is short-term solutions to fill that gap and to fill that need. They have money to carry over just simply because they can't hire a person. But hopefully, if everything's signed, they will have funding to be able to support and leverage up. But we did have that conversation with them, and then also with Child Savers, not necessarily in terms of sustainability, but that this might transition away depending on how the funding streams flow. Yeah, we did.
Not quite. You're talking about the workforce problem, and that's kind of the problem. Is it on?
No, it's fine. Okay.
And that's the problem, but that's it's something deeper than that. So going deeper than that is to where you start to try to get these workers to come is an education piece of it. But do you all work a lot with the local colleges and universities to help with their supporting these people coming into the workforce for counseling?
Our education program officer does. So we do have a teacher residency program. So the way the teacher residency program works in our locality is teachers, and this is specifically for teachers, they are actually under the tutelage of an experienced teacher, and the idea is to kind of keep that workforce building. We have not talked about that as it relates to mental health. I think this is the pilot that would, if how everything goes, it would initiate that conversation. But I think our next speaker is going to really focus on the workforce piece of it. Yeah, because that's his whole presentation, the workforce.
I was going to say, I don't want to scoop myself, but we are going to talk a little bit about the workforce, the school mental health workforce here in a minute.
I think it's a perfect segue, unless there are any other questions. Okay, Mike.
Well, thanks, everybody. So my name's Mike Lyons. I'm a faculty member at the University of Virginia's school psychology and clinical psychology program, and co-direct the Virginia Partnership for School Mental Health. So really excited to talk to you today. Before talking about the partnership, I do want to spend a little bit of time talking about what do we mean when we talk about school mental health, and how do schools think about supporting student mental health needs aligned with their mission. And some of the stuff that we're going to talk about today has already been shared by our panelists, but I just want to provide a slightly different context for that. So when we talk about school mental health, what we're talking about is addressing the mental and behavioral health needs of students to promote educational outcomes, to ensure that they get back in the classroom, that they learn and are able to be successful. We're talking about things like school avoidance, trying to get students who are, especially now, returning from COVID, concerned about their health, their physical health, their mental health, getting them back in the classroom. We're talking about disruptive behaviors and the ways that school staff can help students cope with stress, regulate emotions in effective ways to get them back in the building. So how do we do that? I want you to take a minute to imagine that you've just been hired as the superintendent of a school division here in Virginia. And you are just hired having heard all of the panelists today, talking about the dramatic increase in mental health needs, 50% increase in suicidal ideation, 30% increase in mental health related hospitalizations of students. You've got a big job on your hands. You start thinking about what it means for students in your building. This is 300 students in a building. This is about half of what an elementary school has. Based on, oh, you can't see it there. Based on the recent CDC report, more than 1/3 of these students are reporting persistent feelings of sadness and hopelessness. what do? Well, you have one school counselor. And this is actually down, what's that? We see that, right? You have one school counselor, and actually this is improved. This is better than national averages. National averages are about 400 students. That school counselor is providing assessment support to identify these students, providing intervention supports, responding to teacher concerns, responding to parent concerns. They're also doing a whole lot of other stuff. They're covering classes, they're running the front desk, they are scheduling courses for students, so they are stretched really thin. But they are not alone. In your division, you also have folks like school psychologists who are mostly working with students, as Emily said, at the Tier 2 and Tier 3 level. Those are students who either have a disability or are suspected of having a disability, who are also available to do additional assessment and intervention support for students. They cover about 1,500 students in Virginia. You have a school social worker who is there to help create community connections, to connect with local agencies to help with housing and food insecurity as well as mental health. In your division, just like in Virginia, they cover about 2,000 students. And you have nurses who are specialists on physical health and the ways that physical health intersect with mental health. They're covering about 900 students in your division. You got a big job on your plate. You just were hired. Who else do you have available to you? Well, you have universities. Universities are training the next generation of school mental health staff. They're producing graduates who could be hired into your division. You need to capture them. They also have faculty that are producing new research on what works. How do we implement the assessment strategies? How do we implement intervention approaches that ensure that all students in this division get access to these supports? And finally, you have folks like you. Philanthropy organizations, state agencies, other agencies in your community that are also ready and willing to help. You start thinking about what it is you have to do as the leader of this division to address these needs. Well, one of the things, and we've talked about this a number of times today, one of the things that comes top of mind is that we need more staff, right? We need more staff, and so you imagine what it might look like to double the number of school counselors, psychologists, folks in the building. You have more staff to respond to these needs, but what ends up happening oftentimes is that the voices start to conflict. There are more recommendations, there are more assessment strategies, there's more data that's happening, and sometimes what happens is one student's working with two people who are giving conflicting advice. And other students don't ever receive services. So more staff are necessary, but they're not sufficient. Don't lose hope. You've only been on the job for 8 minutes or so. Don't lose hope, because what we know happens when school divisions select evidence-based intervention strategies, implement those as expected, and work together, the things that you had hoped for when you started your job happen. Students' grades improve, their behavior improves, test scores go up, and they graduate at greater rates because they have the social, emotional, mental health skills to be resilient to the stressors that we're all facing, especially now. That actually has a measurable lifelong impact on students. They're less likely to be incarcerated, they're more likely to get in higher paying jobs, they have better mental health, and they have better physical health outcomes. And you have now just made a significant impact on your community. You've invested $1, and for every $1 that you invest, $11 are returned in lower incarceration costs, in increased productivity, and better health outcomes. Okay, now I want to talk about the Virginia Partnership for School Mental Health. I don't want to pretend that we have all solutions to all of these problems. I want to talk about what aspects of this problem that we are trying to address. The partnership was funded in 2019 by the U.S. Department of Education. It initially represented a collaboration between the University of Virginia, where I and our team are located, and the Virginia Department of Education, along with a couple of the school divisions right around our area. And our broad goal was to increase the capacity for schools and communities to address the mental health needs of K-12 students across the Commonwealth. We started at UVA and James Madison University as 2 university partners, as well as 4 divisions right around us. This year we've expanded to now include partnerships with these additional 4 universities, as well as the other school divisions located here. And what we're trying to do is address or hit 2 goals. And these goals sort of have been talked about by the panelists and others today. The first is to strengthen the school mental health capacity, to strengthen the capacity of the existing workforce in those divisions so they don't end up leaving when they understand the scope of the issue. And the second is to begin to build this workforce pipeline. So I want to talk briefly about how we're doing, thinking about achieving our first goal. To strengthen the school mental health workforce capacity, one of the primary activities that the partnership does is organize professional learning communities. We follow, if you're familiar with the Extension for Community Healthcare Outcomes ECHO framework, it's a virtual online learning community where we have university faculty from the partner divisions as well as some other faculty around Virginia meeting monthly with school mental health staff. We have 4 or 5 faculty meeting with 20 to 40 school mental health staff every month. And every month, okay, 5 minutes, I'm gonna go fast. Every month, the faculty introduce each other. There's a brief didactic where they learn about some new evidence-based practice, and then they spend the bulk of the time doing case consultation with each other. What we hope happens, and what we actually have seen happen, is that in these echoes, the school counselor, school psychologist will bring a problem that they're actually seeing right now in real time to the network and say, hey, I have to address school avoidance with my students, how can I do that? We use that network to leverage the expertise of the school staff in the building as well as faculty to provide and instantiate the research-based practices that we hope the staff are using. The second is that we leverage these professional learning communities to try to begin to build that workforce pipeline. We have faculty that are working with school staff, and those faculty are also training graduate students. And so what we do is we place graduate students in those divisions with those faculty that are participating in the ECHO network. And what we hope happens, what we've seen happen, is that the graduate students get really excited about working in a division that's working on student mental health, that have supervisors and that are engaged in learning the best practices that the faculty are also talking about. And then they go on and get hired. In our small first year of this, when we worked with just UVA and JMU's program, we had 5 students actually graduate and then go and hire into those school divisions. So we've seen some early evidence that that's working. And we've heard this from students. I never thought I wanted to work in this division, and holy cow, I really want to be there now. So I just, in the last couple of minutes, just want to talk about the outcomes that we've seen so far. We are really excited. The first year of the partnership where we launched this work, we collected data, particularly interested in how the school staff were reacting to the types of training that we were doing, and we wanted to see if that changed anything. Did they learn anything? Did that change their behavior? And the data that we collected is encouraging. Generally, 100% of folks reacted really positively to the training. They said things like, I really liked it because it was relatable to what I do on a daily basis. And hopefully, that was our hope with the ECHO networks especially. They said things like, I learned and I felt emboldened to be now part of the school mental health team. I didn't feel like I was just the solo counselor, solo nurse covering 1,500 students, but I had a network of people that I could rely on. And finally, that this actually changed their behaviors, that they took the resources that they learned in the partnership and actually changed the way that school teams here, as an example, ran in their school division. What we hoped happened was that they took those evidence-based practices and used them, and we saw some early evidence in these focus groups that they did. We also collected quantitative data to just look at pre-post changes in their knowledge and confidence to provide these services, and we saw moderate to large positive changes for those school staff. And so we're really excited about some of the early evidence that we're finding. I mentioned this school year had expanded to these additional universities, and so we're this year collecting some additional data to try to understand more about how school staff behavior and knowledge changes as a result of participating in the partnership activities, as well as trying to understand how student outcomes, mental health outcomes actually change. So anyway, appreciate the time. My contact information is there, as well as my colleague Julia Taylor, who co-directs the partnership, and Katie Zena is the manager, and she's here today too. So thanks.
Gold star. Thank you. That's pretty cool, isn't it? So I see a question already. Mary.
So with your second goal and your workforce pipeline question, as you're doing the expansions, it seems like I'm seeing only four-year colleges and universities. And I'm just curious if there's a strategy for reaching students who might be, say, in the second year of an associate's degree and looking at sort of a career pathway from there.
Yeah, that's a great question. So our initial funding from U.S. Department of Education focused only on 4 professional degree school counselors, school psychologists, nurses, and social workers. And so that's why those particular universities that's one of the reasons why those particular universities were selected, and that's our primary outcome for right now. So, but Katie?
Jumping in on that, the other thing is like the requirements for practicing as a school psychologist, a school counselor, a social worker, et cetera, require the graduate level training. And so we're partnering with the universities who have those programs, and we're trying to leverage with the faculty who are there. One of the things that we didn't really touch on is at UVA, like the school counseling program created this school mental health leadership emphasis where they're specifically recruiting students for this partnership who are committing and wanting to work in these high need school divisions. So we're doing a little bit, but it's kind of like one step removed from where we are.
So are there, does anyone know, are there programs or courses of study that are offered in community colleges that would kind of readily lead to these licensed mental health positions?
But I was just thinking there are a number of students, especially these days, looking at just the price of college who start in their 2-year, and they know that they want to do something health-related. There's their nursing track that's at the community college level that I think would be a great fit for, making that tie to mental health and children's mental health.
Programs. And so what I would see is
Yeah.
And one of the things that we did in Richmond, at least temporarily, I don't know what happened to it, was we thought that a good place for these folks to start would be in schools, and we actually found somebody to fund a mentor from VCU who would supervise the kids, because supervision is hard to get.
Yeah.
You need people with the right credentials, and they don't exist yet. And then the practical experience is even harder to get. So part of the reason we're looking at getting the counties and jurisdictions together, we're going to have to bring the schools into that. But if you want to have employees, you need employers engaged. And it turns out that the employers for behavioral health are local governments and local school systems, so they need to be part of the solution.
Well, right, and one of the other things that we've seen, we work with a number of small school, rural school divisions, and in those divisions, you might have one school counselor in the building, and you might have one school psychologist for the division. And so one of the things we're hoping to look at this year is perceptions of burnout among the staff, that if we are able to connect staff, even if they're not part of the same division, but they at least feel like they have a professional network that they can rely on, that we might be able to see some changes there. We saw some of those themes from the focus groups that we did last year, but it's certainly an issue.
Yeah, I'm going to stand right here.
One thing that I'm convinced in our community is that we'll never get to scale in what we need in mental health if we don't do some lay mental health education. And really, so we tried to work with our local public schools to get them to do like youth mental health first aid and things like that, to just sort of create this. Have you guys had any luck with something like that? It doesn't have to be mental health first aid, anybody.
The local CSB, they do youth and adult mental health first aid. And then with NAMI in our community, they do the peer-to-peer educators. So we have that groundswell. That had a lot of momentum, and then COVID. and so I know for NAMI specifically, they have to build that peer-to-peer support in our localities again.
And we haven't done anything specifically with like paraprofessionals or other sort of other helpers. My suspicion is that, in hearing from some of the divisions, that we'd want to be intentional about how to connect those with that other network, right? We don't. The danger is we create more fragmentation, and people are saying, well, mental health, I'm already a teacher, or I'm already a parapro. I can't do that. And so if we're able to help people see how they're part of a team, and that this isn't your problem, but this is a community problem, that we'll be able to get farther there. People will feel empowered. Yeah.
Michael, you spoke briefly about school avoidance, and we know that attendance is really important, that you have to go to school to get the benefit of school, and that the mental health crisis is a big factor in why children are less connected to the adults in the school building. Is attendance an outcome that you and your team are looking to track? Or any other thoughts you might have on that as it relates to mental health, I'd welcome.
Yeah, it's a great question. We're working. So one of the things we're committed to is sort of the partnership aspect of this. We want to make sure that we're being responsive to the needs of the divisions. We're working with divisions to try to, understand what school outcomes, student outcomes that they are particularly interested in, and what data they want to share with us, and how we can be supportive. So we've been moving a little slower, intentionally slower, on the getting the student data. But that is, it's sort of a distal outcome that we're hoping to see. Yeah. Yeah.
The attendance is one of or absenteeism attendance is one of the measures under ESSA quality.
Michael, I'm just thank you so much for all of you for the wonderful panel discussion this morning. Just a quick thought. Are you aware of any programs across the state where universities are training school mental health counselors like yours and so forth? and where the students need supervision, and obviously that can't always occur in the schools. I think one of the things that the pandemic has made very apparent for everyone is the value of telemedicine. And so have there been exploration opportunities where the students being supervised in their academic environments could provide some telemedicine support to the schools? And is there an opportunity for us as funders to help even transactionally provide some of that equipment in our local schools in order to allow them to do telemedicine to provide more resources at the school site?
Yeah, I think it's a good thought. The clinical and school psychology program at UVA does do telemedicine and really was ramping up pre-pandemic, and that's been part of the graduate students training. I'm not sure if any of the other partner universities have an explicit telehealth, telemedicine kind of approach to service delivery. Yeah. All right, great.
Well, and we do know that telehealth can be, we know that telehealth was used during the pandemic for mental health by far, more than for anything else. I attended a webinar where some folks from Deloitte shared that data from looking at claims data and that kind of thing. We also know that in terms of supervision of both MSWs and Masters of Counseling folks, that after they graduate, before they can become licensed, they're required to do 3,000 or 3,000 plus hours of supervised clinical experience, and we know that those hours, that supervision can be provided via virtually, which really helps then spread the expertise to parts of the state that may not have a lot of those licensed supervisors. So it comes into play actually in quite a lot of ways.
If I could just add a couple of things. One is there are limited opportunities to create intentional connections across the community and school providers, right? You can't, if you're a community provider, you're billing for individual services provided. You're not billing for consultation with teachers or sitting on school teams. And so that becomes a real gap because there's a wedge that then can happen between community health providers and school providers. Similarly, with some of the supervision issues, there's not incentive except for the kindness and good-heartedness of the folks that are on staff to supervise and to really devote sufficient time to do that. So that's another gap that can limit universities' ability, for example, to send more graduate students to the divisions. So.
Okay, so now I'm going to just play my role, and so it's